So this is one of three voiceover PowerPoints on the subject of an exemplar of diabetes. This one gives a good overview and talks about some of the treatments. There is also a medication PowerPoint, and there's a complication PowerPoint. So diabetes mellitus is a chronic multi-system disease characterized by hyperglycemia from abnormal insulin production or impaired insulin use or both. In the United States, 29 million people have diabetes and 86 million have prediabetes. It's the leading cause of adult blindness, end-stage renal disease, non-traumatic lower limb amputations, and it's a major contributing factor to heart disease and stroke. And many have hypertension and high cholesterol as well. The theory or the etiology and pathology, there's a theory of cause. It can be a single or a combination of factors that are genetic, autoimmune, or environmental. It's a disorder of glucose metabolism related to absent or insufficient insulin and or poor utilization of insulin. The American Diabetes Association recognized 4 different classes of diabetes. Type 1, or we used to call that juvenile or insulin dependent. Type 2, which is adult onset or non-insulin dependent. Gestational, which occurs during pregnancy. And then there's another cause that is sometimes related to illness. Normal glucose and insulin metabolism. Insulin is hormone is produced by in the islets of Langerhans, released continuously into the bloodstream in small increments with larger amounts released after food. Daily amount of insulin secreted by adults is about 40 to 50 units. It stabilizes the blood glucose level in a range of about 75 to 106 milligrams per deciliter. Normal endogenous insulin secretion in the first hour or two after meals, insulin concentration rise rapidly in blood and peak at about 1 hour. After meals, insulin concentrations promptly decline towards pre-eating values as carbohydrate absorption from the GI tract declines. After carbohydrates absorption from the GI tract is complete, and during the night, insulin concentrations are low and fairly constant with a slight increase at dawn. Further etiology, insulin promotes glucose transport from the bloodstream across the cell membranes to the cytoplasm of the cell, and that's what this picture is showing you. The cell breaks down glucose to make energy. The liver and muscle cells store excess glucose as glycogen and anabolic hormone. Insulin inhibits glyconeogenesis, enhances fat deposits, and increases protein synthesis. Insulin releases glucose from liver, protein from muscle, and fat from adipose tissue. And the picture shows normal glucose transport. Skeletal muscle and adipose tissues have receptors for insulin and insulin dependent. Insulin unlocks the receptors so glucose can move into the cell to be used for energy. Other tissues don't require insulin for glucose transport but still require glucose to function. Liver cells are not insulin dependent but have receptor sites to facilitate uptake of glucose and convert it to glycogen. And there are counter-regulatory hormones like glucagon, epinephrine growth hormone, cortisol, and they may have an opposite effects of insulin. They stimulate glucose production and release by the liver, decrease movement of glucose into cell, help maintain normal blood glucose levels, and insulin is synthesized from proinsulin, which is a precursor. Enzymes split proinsulin into insulin and C-peptide in equal amounts. Serum and urine C-peptide measurements is a good clinical indicator of the cell function and insulin levels. This is a table to compare the type 1 and type 2 diabetes, and we're going to do this as an in-class activity. And this continues with that comparison. Type 1 diabetes is generally at a younger age of onset. Sometimes we called it, like I said, juvenile onset or insulin dependent. It accounts for 5 to 10% of all people with diabetes, and it generally affects people under age 40, but it is often much younger than that. It can occur at any age. It's considered an autoimmune disorder. The body develops antibodies against insulin and or pancreatic beta cells that produce insulin, resulting in not enough insulin to survive. There is a genetic predisposition and exposure to virus that contribute to immune-related type 1. Idiopathic diabetes is inherited, and latent autoimmune diabetes in adults is a slow progressive type 1. Islet cell autoantibodies are present for months to years before symptoms occur. Manifestations develop when the pancreas can no longer produce insulin, and then there's a rapid onset with ketoacidosis. Recent history of sudden weight loss and polydipsia, polyuria, and polyphagia. And we must have exogenous insulin, so they may have a temporary remission for 3 to 12 months after initial treatment, and they do require an exogenous source of insulin. Type 2 is formerly known as adult onset diabetes or non-insulin dependent diabetes. It's most prevalent in type 90 to 95% of diabetes or type 2. Many risk factors include overweight or obese, advancing age, family history. We're seeing an increased rise and have been for at least the last decade of diabetes type 2 in children and adolescents because of dietary problems and sedentary lifestyles. It's greater prevalence in some ethnic groups. Pancreas continues to produce some endogenous insulins, but not enough insulin to produce, or the body does not use the insulin effectively. And that's the major distinction is that in type 1, the body isn't making any insulin at all, but in type 2, it's making insulin, it's just not using it properly. There can be a genetic link, multiple genes, and metabolic abnormalities. Things like insulin resistance, decreased insulin production by the pancreas, inappropriate hepatic glucose production, altered production of hormones and cytokines by adipose tissues, we call those adipokines, and research continues on the role of the brain, kidneys, and gut in the type 2 diabetes. They may develop metabolic syndrome, and if they have metabolic syndrome, and that includes a hypertension, high cholesterol, and hypertension, high cholesterol, fatty liver. They may have like a higher hip to waist ratio, and that increases the risk for developing type 2 diabetes. Especially, and they could also develop people with abdominal obesity are at higher risk for type 2 diabetes. Hypertension, high cholesterol, decreased level of HDLs, and 3 to 5 components equals the metabolic syndrome. Type 2 diabetes is a gradual onset, and what happens is it'll be years that they might have a high glucose level, and maybe they're being monitored and maybe they're not, but that's why we encourage them to have regular routine glucose testing or A1C. At the time of the diagnosis, about 50 to 80% of the beta cells are no longer secreting insulin, and the average person has had diabetes for 6.5 years with type 2. It's a gradual onset, so by the time they're diagnosed, their blood glucose is pretty high. Sometimes it's the acute complication that leads to the diagnosis. Prediabetes, there's an increased risk for developing type 2 diabetes. They have an impaired glucose tolerance test. They have impaired fasting glucose, and their fasting glucose is usually between 100 and 125. They can have both problems, and there's an intermediate stage between normal glucose homeostasis and diabetes. It's asymptomatic, but long-term damage can already be occurring at that cellular level. Patient teaching is very important. They want to undergo screening for glucose and A1C, learn to manage their risk factors, monitor for symptoms of diabetes, maintain a healthy weight, exercise, and make healthy food choices. Gestational diabetes develops during pregnancy. Um, it 2 to 10% in the U.S. Pregnant women can develop gestational diabetes. They're at risk for cesarean delivery and perinatal neonatal complications because they grow big babies. The babies are pretty large. Screen for high-risk patients in their first visit, and high-risk patients include obese, advanced maternal age, and a family history of diabetes. They're at greater risk. The average risk of diagnosis is 24 to 28 weeks gestation, and you would have learned about this in your OB class, and that's about when they schedule that 2 hours, the glucose tolerance test. It's usually glucose levels normalize between about 6 weeks postpartum, and if they are diagnosed with gestational diabetes, they have a 63% chance of developing type 2 within 16 years. Other concerns, it results from injury to or interference with or destruction of beta cell function in the pancreas, and it can be from medical conditions or medications, and it resolves when the underlying condition is treated or drug is discontinued. And you'll see when we go in the hospital that there will be people that are on sliding scale insulin that aren't diabetic, and they'll tell you they're not diabetic, and this is the why. We want to watch their blood sugars because they can be at risk. So these are your classic symptoms of type 1 diabetes. So we've talked about these already, but polyuria, polydipsia, polyphagia. They may have weight loss, fatigue, increased frequency of infections, rapid onset. It's pretty fast that it comes on that they get these symptoms. They become insulin dependent, and there may be a familial tendency, and peak incidence is from age 10 to 15 years old. Type 2 diabetes, they're very nonspecific symptoms. Classic symptoms of type 1 may manifest, and those include the polyuria, polydipsia, polyphagia. They can develop fatigue, recurrent infection, recurrent vaginal yeast or candida infections, prolonged wound healing, visual problems. Average age is 50 years or older, history of hypertension, fatigue, and I said everything else. They may have a sedentary lifestyle. Diagnostic studies include the A1C, and we're looking at A1C 6.5% or higher. And we're going to do an in-class activity to look at diagnostics. Fasting blood plasma glucose level of greater than 126, 2-hour plasma glucose level greater than 200. They will repeat criteria 1 to 3 on another site visit another doctor visit to confirm. Be attentive to influencing factors. Classic symptoms of hyperglycemia or hyperglycemic crisis or random plasma glucose level greater than 200. We talked about A1C already. A1C is also called glycosylated hemoglobin, and it reflects the glucose levels over the past 2 to 3 months because there will be a change in the cell wall. Glucose attaches to the hemoglobin molecule. Higher the glucose level is, the higher the A1C. It's used to diagnose, monitor response to therapy, and screen patients with prediabetes. The goal is less than 6.5% to 7%, and that reduces complications. Fructosamine reflects glycemia in the previous 1 to 3 weeks, may show change before A1C. Used for hemoglobinopathies and short-term measurement of glucose levels. Islet cell autoantibody testing, and they may also do lipids, BUN, creatinine, electrolytes, albuminuria, and urine acetone. They're going to check the blood pressure, the ECG, the eye exam, make sure they have an eye exam, dental exam, foot exam, neurological exam, and measure their weight. So the goals of diabetes management are to decrease the symptoms, promote well-being, prevent acute complications, delay onset and progression of long-term complications. They need to maintain a blood glucose level as near to normal as possible. And remember that with our type 2 diabetics, sometimes that's a little higher than what we would think. We want to make sure that the patient and the caregiver understands, recognizes complications, and understands how to administer emergency treatment if needed, and is on board with dietary and lifestyle changes. And type 2, we want to really encourage living a healthy lifestyle, getting enough adequate exercise, and has good dietary management. Medication therapy, and that's a whole different presentation. Nutrition therapy, we want to develop individualized plan for diabetic and pre-diabetics, and that should include counseling, education, ongoing monitoring. Consider behavioral, cognitive, socioeconomic, cultural, religious backgrounds and preferences. We may need an interprofessional team, and that should include a registered dietitian with expertise in diabetes management. Other people of the team would be nurses and maybe social workers, healthcare providers. We can follow ADA guidelines. Diabetic eat the same food as non-diabetics, and we can look at things like the MyPlate. Our goal is to achieve and maintain safe and healthy blood glucose levels. And I said that already. Normal lipid profiles and blood pressure prevent or slow complications. Individual needs, personal cultural preferences. Maintain pleasure of eating with healthy choices. And the food composition, healthy balance of nutrients is essential to maintain blood glucose levels and overall health. Energy from food intake can be balanced with energy output, individualized to lifestyle and health goals. We want to limit alcohol to a moderate amount if no risk for other alcohol-related problems. 1 drink a day for women, 2 drinks a day for men. It inhibits gluconeogenesis by the liver and can cause severe hypoglycemia. Eat carbohydrates when drinking unless drinks have sweetened mixers. Create trust so patients honestly report intake. Glucose is harder to manage if they do not. Food composition includes carbohydrates. It's an important source of energy. Fiber, vitamins, and minerals. Intake is individualized. Includes sugar, starches, and fiber. Fruits and vegetables, whole grains, low-fat dairy. All benefits from including dietary fiber. Should be about 25 to 30 grams per day. Nutritive and non-nutritive sweeteners may be used in moderation. Fat provides energy, transport of fat-soluble vitamins, and essential fatty acids. Saturated fat intake is individualized. Limit cholesterol to less than 200 milligrams per day and minimize trans fats, which decrease the risk of cardiovascular disease. Healthy fats come from plants, olives, nuts, avocados. Protein, daily protein intake is individualized, same as non-diabetics and people with normal renal function. Lean protein is recommended. Specifically for my type 1 diabetic, meal planning is based on usual food and intake and preferences, balanced with insulin and exercise patterns. Day-to-day consistency makes it easier to manage blood glucose level. Rapid-acting insulins, multiple daily injection, and insulin pump offer flexibility based on current blood glucose levels and carbohydrate content of the meals. For type 2 diabetic, emphasis is on achieving glucose, lipid, and blood pressure goals. Moderate weight loss, 5 to 7%, improves insulin sensitivity. Nutritionally adequate meal plan, appropriate serving size, and reduced saturated and trans fats, and low carbohydrate can decrease calories. Spacing meals and regular exercise are also important. Effectiveness of therapy monitored by blood glucose levels, A1C, lipids, and blood pressure. Patient teaching about nutrition, we really need the dietitian to provide initial instruction. The nurse may have to assume some responsibility for that. Carbohydrate counting, track amount of carbohydrates with each meal. Serving size is 15 grams of carbohydrate, and typically you have 45 to 60 grams per meal. Insulin dose is based on the number of grams of carbohydrates consumed. For example, 1 unit per 15 grams of carbohydrates. Patient teaching, to teach the patient to read the labels and what the serving size is. There are diabetic exchange lists. Prescribed meal plan with specific number of servings from a list of exchanges for meals. So think about like a Weight Watcher list, or how we used to do Weight Watchers, where you need 2 milks for the day and you need this many proteins and this many fats and this many carbohydrates. Helps them plan easier. Exchanges: starch, fruits, milk, meat, vegetables, fats, and free foods. The USDA has the MyPlate guidelines. Usually it's a 9-inch plate. Half of the plate should be non-starchy vegetables, quarter starch, and a quarter protein. Add 8 ounces of a non-fat milk and small piece of fruit. And family members and caregivers, especially those who do the cooking, should be included in any education and counseling. Self-care skills are encouraged because it deters reliance on others to make the decisions. Exercise, regular, consistent exercise plan is essential. The ADA recommends for these diabetics at least 150 minutes per week of moderate intensity aerobic activity. Resistance training 3 times a week. Benefits: it decreases insulin resistance and blood glucose, promotes weight loss, and that's more for our type 2 diabetics. Our type 1s don't have that problem, generally speaking. Reduce needs for medications in our type 2s, decreases to triglycerides and LDL, and increases to HDL cholesterols, decreases blood pressure and increases circulation. Get medical clearance, start slowly, and progress to goal. Insulin, sulfonylureas, or megalotidines plus physical activity can cause hypoglycemia if occurs at peak time for medication or didn't eat enough. May happen, and so we need to make sure that they monitor that. May happen if sedentary diabetic suddenly becomes more active. Glucose lowering effect of exercise lasts up to 48 hours. Encourage exercise 1 hour after a meal, or to have a 10 to 15 gram carbohydrate snack, and check glucose before exercise. Carbohydrate snack to prevent hypoglycemia every 30 minutes while exercising. Risk for hypoglycemia, I already said that with exercising. Carry a fast-acting source of carbohydrates. Frequent low glucose, consult your healthcare provider about lowering medications. And effective strenuous activity makes the body perceive stress, causing a release of counter-regulatory hormones and temporarily increase the blood glucose. So we have to be aware of that, because then we might be treating the blood glucose that is not is like artificially high. Type 1, delay activity if glucose is greater than 250 and ketones are present in the urine, because that makes the condition worse. Self-monitoring of blood glucose is how it's normally done. It enables decisions regarding food intake, activity patterns, and medication doses. Accurate record of glucose fluctuations and trends. Recommended for all diabetics who use insulin and others to help achieve and maintain glycemic goals. Frequency of testing varies according to those goals, to the medication plan. So the frequency of testing can vary according to the goals, the patient's individualized goals, and their medication plan. It does allow them to independently check their glucose. They need to make sure they have access to the supplies and equipment, and willingness and ability. Usually if they have multiple insulin injections in a day, or if they have an insulin pump, they need to check their blood glucose every 4 to 8 times per day, unless they have a continuous glucose monitor. Other therapies as needed to meet goals. They may be a portable blood glucose monitor. Many products are available. There's a lot listed in your chart, in your book. Lancet for a small drop of blood. Blood goes on the reagent strip. The monitor displays the digital reading of blood glucose. Technology changes with newer and more convenient systems. Alternative blood sampling sites include the forearm or the palm. I've never actually done that to anybody. I've only ever done their finger. It's not recommended for rapidly changing readings during pregnancy or hypoglycemia. The data gets uploaded to a computer. They can also have continuous blood glucose monitoring for type 1 or type 2. Insurance coverage and costs may limit the use of continuous blood glucose monitors. Some pumps have the continuous blood glucose monitor integrated within the pump. And flash glucose monitor is they wave a reader over sensor and get a reading. I've not seen that myself. Subcutaneous sensor displays glucose values on a pump or pager-like device, or smartphone updates every 1 to 5 minutes. Reads interstitial versus blood glucose, lags behind 5 to 10 minutes, helps identify trends and patterns, and the goal is a specific time and range with fewer highs and lows. Alerts to hypoglycemia or hyperglycemia. No need to check finger stick first before making insulin dosing decisions with the continuous glucose monitor. Other management of diabetes includes bariatric surgery. Patients with type 2 diabetes or associated comorbidities, when the lifestyle and drug therapy management is difficult or they need lifelong support and monitoring, they may have some type of bariatric surgery like a Roux-en-Y or some other type like that. They need lifelong support and monitoring. For type 1 diabetes with end-stage renal disease, that they may need to get a kidney implant transplant, they might also have simultaneously a pancreatic transplant at the same time. So if no renal failure, ADA criteria for pancreas transplant includes history of frequent, acute, or severe metabolic complications requiring medical attention. Incapacitating clinical and emotional problems with exogenous insulin, consistent failure of insulin-based management to prevent acute complications. If successful, the pancreatic transplant improves their quality of life. It eliminates the need for exogenous insulin, blood glucose monitoring, and associated risks with hyper and hypoglycemia. Can also eliminate acute complications with type 1. Long-term renal and neuro complications may persist. But they will have to be on lifelong immunosuppressant agents. Options also is an islet cell transplant. Donor islet cells are infused into portal veins of the liver, and that's still considered an experimental transplant. To focus on the culture, culture can have a strong influence on our dietary preferences and meal prep. High incidence of diabetes in some cultures like Hispanic, Native American, Blacks, Asians, and Pacific Islanders. It's important to consider food preferences and when teaching about nutrition. Check the ADA resources and remember that it's always better to start with what they like to eat because it's very difficult to attain adherence to dietary changes if you're giving them something they've never eaten in their life. So it's important to include where their starting point is. Nursing assessment is going to include past health history, including things if they've had a lot of viral infections, trauma, other infections, stress, pregnancy, chronic pancreatitis, Cushing's syndrome, acromegaly, family history of diabetes. We need to know their medications. Are they on insulin? Are they on oral anti-diabetic medications? Are they on any steroids, any diuretics? Are they on phenytoin for seizures? Have they had recent surgery or other treatments? Some subjective data includes their functional health patterns. So how do they perceive their health? What's their family history? What's their metabolic, nutritional needs? Are they obese? Have they had a weight loss or gain? Thirst, hunger, nausea, vomiting, poor healing, dietary compliance, elimination. Are they constipated? Do they have diarrhea, frequent urination, things like that? Subjective data continued. How's their exercise? Do they have any muscle weakness, fatigue? How's their cognitive or perceptual status? Abdominal pain, headache, blurred vision, numbness, tingling, pruritus. Sexual, reproductive, are they impotent? Frequent vaginal infections, decreased libido. And how is their coping stress, depression, irritability, apathy, and their commitment to lifestyle changes. My objective data, I'm going to check my eyes. The eyes, I'm going to look for soft sunken eyeballs, history of vitreal hemorrhages, cataracts. I'm going to check their skin for dry, warm, inelastic skin, pigmented skin lesions, ulcers, loss of hair on toes, acanthosis nigricans. Respiratory, I'm going to look for Kussmaul respirations. Cardiac, I'm going to check for low blood pressure, weak or rapid pulse. I'm going to look at my GI tract for dry mouth, vomiting, fruity breath. Neurologically, I'm looking for altered reflexes, restlessness, confusion, stupor, coma. Musculoskeletal, I'm looking for muscle wasting. And then I'm going to look at their lab values and look at their fasting blood glucose level, their electrolyte levels. For elevated white count, blood urea, nitrogen, creatinine, and other problems with cholesterol. Hemoglobin A1C, and I'm going to check their urine for glucose, ketones, and albumin. Nursing diagnoses include lack of knowledge, hyperglycemia, hypoglycemia, risk for injury, impaired peripheral neurovascular function. Planning, or my overall goals, is that the patient will engage in self-care behaviors to actively manage diabetes, few or no hyperglycemia or hypoglycemia emergencies, maintain normal or near normal blood glucose levels, prevent risk for chronic complications, adjust lifestyle to accommodate diabetes plans with minimum stress. Nursing implementation is going to include health promotion, so we want to actually identify, monitor, and teach patients at risk. We want to look at their risk factors like obesity. We would encourage weight reduction and increase exercise, routine screening for all overweight or obese adults with one or more risk factors. And other risk factors include age and ethnicity. We've talked about that already. Having a baby greater than 9 pounds at birth, history of gestational diabetes, and family history of diabetes. They should do a self-diabetes risk test. Acute situations include hypoglycemia, diabetic ketoacidosis, hyperosmolar syndrome, and we talk about those in the acute complication PowerPoint. Acute illness and surgery. They could have physical and emotional stress that causes increased glucose. Stressful situations like acute illness, injury, or surgery may require more intensive treatment to maintain glycemic controls, because remember, the blood glucose is going to increase because of the counter-regulatory hormones. So while they may not be eating or whatever's happening, their body's responding by increasing the blood glucose. We want to, if possible during acute illness, maintain a normal diet, increase non-caloric foods, continue taking diabetic medications. If eating less than normal, supplement with carbohydrate-containing fluids while continuing the medications. If unable to eat or drink, they need to contact the healthcare provider. If there's an intraoperative, for during surgery, we want to give IV fluids, and we may need to give a sub-Q insulin when they're NPO. Inform type 2 diabetics that insulin may be temporary and not a sign of worsening diabetes. For the unconscious patient, we want to frequently monitor their blood glucose, monitor for hypoglycemia, sweating, tachycardia, and tremors. And in the ambulatory setting, overall goal is to enable patient with the caregiver's help to reach an optimal level of independence in self-care activities. Successful outpatient diabetes management requires ongoing interaction with interprofessional team, including the dietitian, and many challenges to face with risk for chronic conditions that impact self-care activities. Acute care specifically, we want to check, so diabetic patients should check their blood glucose every 4 hours during time of illness. And if glucose is greater than 240, check urine for ketones every 3 to 4 hours. 2 consecutive glucose levels greater than 300 or moderate to high ketone should be reported to the healthcare provider. Increase insulin for type 1 diabetics to avoid DKA. Increased glucose increases risk for infection and reduces healing. Type 2 diabetics may require insulin to get over this hump and avoid a hyperglycemic emergency. Critically ill patients may have a higher target goal of 140 to 180 milligrams per deciliter and may get insulin if glucose is consistently greater than 180. In ambulatory care, you want to assess the patient's caregiver ability to perform the blood glucose and insulin injection, obtain assistive devices. Self-management requires dedication of time and energy to deal with lifestyle choices, diet, medication, exercise, and preventing or managing complications. Patient and caregiver education needs to include understanding, really teaching them about the disease and what that means to their lifestyle. Determine the mutual goals that are based on patient needs and treatment plan. Identify a support system in planning, teaching, and counseling. In the complications PowerPoint, I tell you about a patient I had when I worked in Seattle, and he came in with diabetic ketoacidosis 3 times, and maybe it was this PowerPoint because they're all running together for me now, but he came in 3 times in 3 months because he really was having trouble adjusting his lifestyle. When you have kids, my husband's an elementary school teacher, and if they have somebody who's a diabetic, they usually will pair them up with a buddy so that they can help recognize when signs are occurring. So, because they can't always recognize their own signs of hypoglycemia or hyperglycemia. So we want to provide emotional support and encouragement. Insulin therapy, the nurse's responsibilities include proper monitoring, administration, and patient response. And we want to teach the patient how to do their own insulin as well. Monitor blood glucose, record for review, Interactions of insulin, food, and activity. Um, how to manage hypoglycemia. How to do other medications, when to give appropriately the oral or non-insulin injectables, and make sure that we're monitoring patient response. And personal hygiene, regular oral care and dental visits, regular bathing and foot care, inspect their feet daily, avoid going barefoot, make sure that they're wearing properly fitted footwear. And how to manage a wound, so when to report a non-healing wound to the healthcare provider. They should always have a medical ID and when they travel, and carry the medical ID at all times. Medical alert or identification card. Plan ahead if you're going to travel, especially if you are traveling to, like you're going to be traveling and not eating your own food and have no control over your meals. Like on a cruise, you want to make sure that you alert people, and that you need to make sure that the equipment is okay, because you might need a letter from your healthcare provider saying it's okay to have the needles and syringes because of TSA guidelines, and the snack. Goal for self-management is you really want them to be able to be active participation for better outcomes. You want to empower them to be a partner in their care. Now, one other little story, and then I've got one more slide. So many years ago, I was an LPN still. So that was a really long time ago, before many of you were born. There was a hurricane in the Gulf, and it ended up stalling out, but it was going to hit Tampa. And where it was the most, the areas that were flooding were like the Lithia, Gibsonton, Alafai River kind of areas. I lived in North Tampa at the time. And the Red Cross called and said said they needed nurses to volunteer. And so they sent me out to Lithia Pinecrest Elementary School. Maybe some of you went to there. Because the school was evacuation site. And I was there overnight. And I had these two little old ladies that came to talk to me about their diabetes and how that dinner hadn't been adequate. So I had never volunteered for the Red Cross before. And they called me like every couple hours. Do you have enough diapers? Do you have enough blankets? I had a couple of patients that were there, but there were a lot of people there. And then they were going to bring, so when they called about the diapers and blankets, I asked them about what breakfast was going to be, because I had these two diabetic ladies who came and told me that they forgot to bring their insulin with them. And I said, well, that's the first thing you're supposed to do. That's what they tell you when they evacuate you, is bring your meds. But next thing I know, so I told them about that. The next thing I know, it was like the SWAT team came running in there, these big guys in black, and they came running in with a bottle of insulin. So here's the bottle of insulin, and FYI, no syringes, no needles, no way to give this insulin. So meanwhile, they came in and say, oh, we heard you have somebody in a diabetic coma. No, I don't. I have these two little old ladies that forgot their insulin at home. That's what I have. Well, here you go. I'm sure that insulin is probably sitting in that fridge in that staff room at Lithia Pinecrest Elementary. And I'm really just kidding. I'm sure that this many years later, they cleaned out their fridge. They probably didn't know what to do with that insulin. I didn't know what to do with that insulin because I had no syringes or needles to do. So then the principal announces over the intercom, if you have any dietary needs, that breakfast is going to be cinnamon buns and applesauce, and please come see the nurse. And then all of a sudden I had this like line of people, and still had these two little old ladies who had no way of getting their insulin. So another nurse came in the morning. The hurricane stalled over the Gulf, just stalled there. So we're getting lots of rain, but then it went to Cedar Key or somewhere north of here before it hit land, and it had downgraded to a tropical storm or whatever level by the time it hit land. Moral of the story is that the two little old ladies, when I was walking out to my car, they said, oh, Laura, we're just going to go home now. We'll just take our insulin at home. So, moral of the story is that make sure that if you're diabetic, that you bring your supplies, especially if you get evacuated in a hurricane. And you cannot, as I tell you on the medication PowerPoint. You cannot take insulin orally because it's destroyed by the gastric juices. So, evaluation, expected outcomes. These are the expected outcomes based on our plan. They state key elements of this treatment plan. They describe their self-care measures that may prevent or slow progression of chronic complications. They maintain a balance of nutrition, activity, and insulin availability that results in stable, safe, and healthy blood glucose levels, have no injury from decreased sensation in the feet, implement measures to increase peripheral circulation, and that is the end of this PowerPoint. Thank you.